thank you very much, Professor Brian DeLuhui, for organizing this. This is quite a unique conference. I'm not aware of any other conference where we have patients and physicians together. No other conference where the most challenging question comes from the patients, because we physicians know the answer, we don't want to offend, we don't want to ask anything like that, so boom, and that the patient comes with the answer. And yes, in order to understanding that the next speaker is online, so I will fulfill the 30 minutes. The genesis and development of ideas on surgery for Chiari. Dr. DeLuhui just said in his talk that posterior fossa decompression is the most common and the most effective treatment for this metapathology. But as one of the patients who asked at a question in the morning, it says, "How do you know? How do we came with the idea of doing posterior fossa decompression? Who came and how did the concept came?" So the subject in itself is the history of the ideas, which is now going forwards in many venues and in many shops. There is a future conference in Warsaw in September, maybe around your birthday, most, that talks about the School of Ideas in the neurosciences. People are more interested in trying to know from where do you come with that particular concept. The ideas precede knowledge, no? And the ideas are attained through empirical familiarity with objects in this world, and from which one creates universal concepts. There is a picture in our room here at the hotel, which are 8 baseball players coming out of a cornfield. Yes, we know that's from the movie Field of Dreams and all those things, right? But we know those things because we are here and I'm here and I saw the movie. If you bring somebody from another country, throw in there is 8 guys in white uniform and a green background. And also so ideas come through an empirical understanding and empirical knowledge. And this is falling. I am holding, I can hold it. And our knowledge begins with experience, with something that we see, something that we go and think about. It doesn't begin our knowledge with anything else but from experience, right? And so this conference, it has under this the motto of neurosciences and patient care, from where we get the ideas from you. From where the surgeon who operated me last year get his ideas, maybe from me or from the experience he had with other patients. And the thing is, there is a constant dialogue between the neuroscientist or the neurosurgeon, the neurologist. We encompass all of them as a neuroscientist, and the patient, but as the logo implies, is a two-way dialogue, and we will go about that. So our first encounter with the patient is motivated by our interest of the care of that individual. We are informed by science, and we are guided by reason. And there are only 2 ways in which we approach the patient, in which you approach any other task that you have to do, which is the intuitive or the deductive. The intuitive is the one I did yesterday when I came to my room and I didn't think about, so that painting of the guys, or that refers to the movie Field of Dreams. Maybe not. But I thought about that, and that was it. That's the intuitive knowledge. The intuitive knowledge tells you have headaches because you have Chiari. and or the intuitive knowledge in the patient that Brian discussed this in the morning so well, of the patient with a Syringomyelia and at the tumor, the intuitive knowledge of the first surgeon who saw that patient, oh, is the disc. Without thinking, or without thinking, no. They actually thought, but they were overcome by their intuitive knowledge. And the other one, which is the best one, is the deductive knowledge. Start thinking and pondering and coming with a solution. This phenomenon happens in our brains. We have an area for intuitive and we have an area for deductive. We use that constantly, not only when dealing with the patients or dealing with the problems in your daily life. We use it constantly when we try to find a way to go from point A to the point B. There is an area for intuitive knowledge. Both are in the right hemisphere. In the prefrontal, one is slightly superior and another one is slightly inferior. And yes, there is a paper that proves that to be right. So you have the patient, and then you recognize what the patient has, or you don't recognize what the patient has. You see the painting, and based on that, you calibrate and reach a diagnosis. So who was that first patient? Who was that first patient that showed up and somebody said, posterior fossa decompression is the solution for your problem? And the concepts are not spontaneously created, but are determined by their ancestors. So who was the ancestor? Years ago, with a medical student, then now senior resident at Mass General, we did a literature research trying to find which was the first paper, the paper that somebody quotes indirectly and kick the question ahead. And we came to this paper by Dr. Penfield in 1930. He published in 1938, but it was of a case of 1935. And I will briefly expand on the merits on Dr. Penfield and Dr. Bucy, and together with Irene, and propose a hypothesis. Canada in 1935 was a country in economic disarray, as was most of the world, but the Canadians suffered the most compared to the heavy toll on the American society. And that led in 1935 for a significant political change when the liberals defeated the conservatives, and the late great Canadian Mackenzie King ran the government for many, many years. No? But 30% of the Canadian force was unemployed. In 1934, the Montreal Neurological Institute was opened. Dr. Penfield, an American, was in charge, a young American was in charge. And in this paper he says, a woman aged 29 who was admitted to the Montreal Institute had an operation at the age of 3 to repair a spina bifida with meningocele, not minor meningocele. And in order of time, what caught my attention is he says she said that she had lost her position as bookkeeper because tears that she could not wink away fell on her work. My mistake was telling was a librarian, but no, she was the bookkeeper. So this is a smart and a kind observation from a surgeon, quite different from the case reports. In the case reports that I wrote, you will not find such a sensitive paragraph as this one by Dr. Penfield. So bookkeepers in 1934 and in 1935 demanded an extensive amount of intellectual ability. So we are seeing dealing with the person who was extremely well educated or extremely smart, up to the standards, who lost their job in a moment and there were no sufficient, there was a high unemployment. And also she was a woman, no? So women were increasingly entering the workforce, including the clerical and bookkeeping positions. This is the lady on the physical examination. Yes, indeed, she had a facial palsy, and indeed she had a small scar of meningocele. She had some ataxia, she had nystagmus, sometimes double vision, but basically the reason why she came to the Montreal Neurological Institute is because she couldn't tear away or wink off the tears, and she lost her job because those tears fell on the work she was doing, on the books she was keeping, or in the. Why did I think she was a librarian? That's a mystery. Anyway, so on November 1935, with a tentative diagnosis of tumor of the acoustic nerve bilaterally, a suboccipital craniotomy was done with the patient under averting and ether anesthesia. So she was basically local anesthesia. No? Averting is used only today for experimental animals. It's done intraperitoneal. And ether anesthesia is confined only for very remote areas of the developing world because it's extremely cheap, but it's very inflammable. But it was used in Canada in 1935. So basically under not intubated under forms of local anesthesia, she had a surgical procedure, and they removed the whole occipital bone. Was a craniotomy, not a craniectomy. Remove the whole occipital bone, explore the area, didn't find any tumor. But then Penfield said, oh, I found that the cerebellar tonsils are down, are sort of pulled downwards. And he writes in that fantastic paper, I remember a paper by Chiari. And somebody points, listen, she has a meningocele in the back. I say, so maybe there is some traction. Maybe the meningocele, that the scar is making traction, is pulling downwards the cerebellum. So he freed the cerebellum. He says that the cerebellum went up 3 centimeters. Remember, it's Canada, they are not doing inches. It went up 3 centimeters, and he said, well, the issue is partially solved. And then he made these drawings in which you see the meningocele here and the cervical spinal nerves going upwards, no? Because there was downwards traction, no? And with that is the first paper where he says Chiari malformations are not always associated or shouldn't be associated with myelomeningocele, with severe spina bifida, which was what Chiari and other people described. They say, careful, it comes in other forms as well. Diagnosis in retrospect, it seems that we should have suspected the Arnold-Chiari malformation. Instead, a suboccipital craniotomy was carried out with a tentative diagnosis of tumor. So instead of there kind of being a pathological curiosity, as the rarity of reports in the literature and then would indicate, the anomaly may present itself as an unexpected clinical problem to be dealt by the neurosurgeon. So was that the first person who said, careful, Chiaris do not come the way that we think that they come, and maybe the solution is doing a suboccipital craniectomy. And that's how the idea came of the craniectomy. At the close of the operation, the patient condition seemed excellent, but the patient died 2 months after without recovering consciousness. So this heroic patient, the bookkeeper who couldn't wink, died in the surgical procedure. Penfield commented on the case. He gave some explanation why he believed that that the patient died. But so from this point in which he said that there was be careful with the Chiaris, there is a British pathologist, Dr. Arin, who says in his papers, through the kindness of Coburn and Penfield, I have been informed of a case which are reported elsewhere. This is a case of a female patient, age 29, and he was comparing what had with Penfield with a patient he was seeing, a young man which he thought he had cerebellar ataxia. And then he said, oh, no, maybe he doesn't have cerebellar ataxia. And then Adams, in 1942 or 1940, because I can't read from there, also describes another case, and they say, and quotes Penfield and Arin, and I say, careful, that is the thing. And by the way, we did exactly what Penfield did. We did a suboccipital craniectomy, and in this case, his patient did very well. And then finally, Dr. Bucy and with Dr. Lichtenstein, they presented that the case of a 40-year-old lady who didn't have any malformation, anything. Bucy does the surgical procedure believing that the patient will have a posterior fossa tumor, a CP angle tumor, because it had similar symptoms. And then he says, more or less, in English that was available in that time, he said, darn, I should have remembered Penfield. This is the same case as Penfield did. And in the Bucy drawing, in his paper, is the similar surgical procedure that has been very common until we decided to reduce the extent of the occipital craniectomy. And yes, he quotes in there. And yes, I did a correction of a Chiari on a baby in which we repair the meningocele, again, following Penfield. And finally, in 1947 or 48, Dr. Mallis, he says, we have eventually agreed upon an operative regimen which has been recognized as giving the high percentage of successful results. And they only quotes Penfield, Arin, and Bucy. So from this patient, M&M, a chance encounter between a neurosurgeon and the patient, developed this the concept that the posterior fossa decompression was effective for the Chiari. Bucy patient did very well. All the patients described by Dr. Mallis, 6 or 7, did very well as well. So when a conception permeates a thought collective strong enough, penetrates as everyday life and idiom, and becomes in a viewpoint in the literal sense of the word, and any contradiction appears unthinkable and unimaginable. How will not you do a massive suboccipital craniectomy if it's effective? But all true scientific therapies accept falsifications, the demonstration that they are true, unless someone proves them false. And this is the famous thing Popper says. If you are facing this field, the only thing that you can say is that not all swans are white. That you cannot say there are two colors of swans. Not all swans are white. Maybe one day we'll find a pink swan. And not all swans are white appeared when we start seeing patients with a massive descent of the cerebellum because an extensive craniectomy. And so there is a list of the authors over there who try to find different ways of reducing the craniectomy, doing craniotomies, not so extensive craniectomies, just removing the foramen magnum or the tonsils, or doing only C1 and not C2. A series of problems that are faced by some of the patients today. So, as a clinicians, we reason, as we said, through induction and deduction. You have this, I did this test, you need this based on the experience. Or, I don't know exactly why you have headaches, the causes of headaches are these, let's consider Chiari. But the way all my colleagues think now is through abduction. Abduction is a phenomenal concept created by the greatest American philosopher, Charles Stanford Pierce, and who is the father of pragmatism, no? But he was a mathematician, a logician, was a man of intensive intellectual activity. And he said, instead of moving from general principles to specific instances, or from general from the general to the individual, or the individual to the general, you have to look backwards and think individual of each one of the cases. And each one of the cases are you and are we, are everybody who ever has been at a patient. Each one of the patients has to be thought in an independent manner. And then, okay. So the deduction, if you have a rule patient result, in deduction you have patient result and rule, and adaptation ends in the patient. Bear with me. So if you have this patient with Chiari 1 as headaches and ataxia, we expanded the volume of the posterior fossa and the patient improved. A rule in patient with Chiari 1 and ataxia and headache, consider expanding the posterior fossa. That's deduction. I'm sorry, that's induction. Deduction goes the other way around. You have a rule that the patient comes with a posterior fossa with an MRI confirming that the posterior fossa, you do the posterior fossa decompression, and the patient does well. But then you do abduction. Starts with a rule, confirms the result, and validates the rule, and goes to the patient and asks, why this one? One thing that puzzles me in this is on the part of development of ideas. No? We had the genesis of the idea was Chiari, Bucy, Malice, and now how do we face the future challenges? No, and so fine, that the patient did very well, but the doctor says, no, come on, you have a 4 millimeters descent of the tonsil, and you have a flurry symptoms, and you have 2 centimeters of the descent of the tonsils, and nothing happens, or just barely headache, or sometimes headache. Why we don't correlate? We are still not able to correlate the radiology. Maybe with most movements we can move forward, but the idea of the question is question or be motivated by each patient. And that the motivation does not happen all the time. It so happens that you face a patient who, like a good teacher, gives you direction to your confused thinking. And that is noticeable, particularly in the way that people present one case. I was paying attention to your lectures, Brian. This morning I was impressed when you said that lady who sneezed and had the pain in the back, and she thought that was all the time natural. That is an observation. That patient is your teacher. And similarly and I go back to what really impressed me, is that the bookkeeper who could not wink. And Bucy, who had a fantastic, whose paper is part of the formulation, is the first paper that shows that Chiari does not come necessarily associated with a myelomeningocele or a spina bifida, and that the posterior fossa is the decompression of the posterior fossa is effective. He writes in his a case report, when after a day of unusual hard work, her legs gave way and she slammed to the floor. That's an emotion. That is not just a neurosurgeon saying 7th nerve, 5th nerve, we open, no? A totally unnecessary line, both of them. But those unnecessary lines are similar to that's my time? No. Those unnecessary lines are similar to your line with the lady who thought that the life was. So in essence, this conference, this group of Syringomyelia and Chiari in its 37 infection is a dialogue between neuroscience and patient care. Without your input, we are nothing. And without us being attentive to some of your problems, we are not advancing and we are not going anywhere. But as I said it here, it does not happen all the time, no? And only happens when the things anyway happen. Thank you. Thank you. Thank you.